and heartily welcome to my presentation about the challenges of histology and the unique findings following LANAP treatment of hopeless teeth. I'm a biologist. I spent 20 years at the University of Zurich as a histologist. Then I started my own company, the Schupbach Ltd. In Switzerland, which is a service and research laboratory for histology, imaging, and electron microscopy. I will show you a lot of images today, images as you probably never saw before. And please be aware that a lot of these images are not yet published, meaning that they are copy protected by my company. The primary goal of periodontal therapy is to establish periodontal health with pocket reduction and attachment gain, preferably through periodontal regeneration. Well, this is probably no news for you, but it is important to be aware that regeneration is defined as the reproduction of a lost part of the body in such a way that both the architecture and function of the injured tissues are completely restored. And this means for the periodontium that the structure and function of the gingiva, the alveolar bone, root cementum, and the periodontal ligament must be restored. These prerequisites that we have exact knowledge about the healthy periodontium, namely the ligament, the supracrestal fiber apparatus, the junctional epithelium, and the peripheral defense. Then I will show you the histologic challenge I had to prove periodontal repair or regeneration. And finally, I will show you the findings following LANAP treatment of hopeless teeth, the study Mark Nevins conducted and published in 2012. The periodontal ligament is a connective tissue in the place interposed in the small gap between the root surface and the alveolar bone. This connective tissue is composed by dense fiber bundles, and these fiber bundles are anchored deeply on one side in the mineralized cementum and on the other side in the alveolar bone, respectively. Each single fiber bundle is composed by hundreds of tiny, thin collagen microfibrils. Thereby, this attachment of the tooth acts like a suspension. It's a wonderful solution of attachment. The evolution brought us this suspension-like attachment allows, or let me say, will avoid damage by excessive occlusal load. If you go even higher in the magnification, then you may see in a spectacular way that each single fibril here is attached to the cementum surface, and that is not all. When we make nanometer cuts through this area, then we will see that each single fibril is deeply buried and anchored in the mineralized root cementum. If we look to the same area in polarized light, then we see here the cementum layer and how deep the fiber bundles are anchored in this cementum layer, and on the other side in alveolar bone. Here it's not clearly to see where the border of bone is. Therefore, I show you another light microscopic image of this area. You have here the osteoblasts and the osteocytes, and the collagen fibers, which are deeply buried here in the alveolar bone. You can follow here the course of the fiber along these dark lines. The periodontal ligament is supported by the supracrestal fiber apparatus. This fiber apparatus is composed by different kind of fiber bundles, the interpapillar fibers, the transgingival fibers, the intercircular fibers, and the circular or semicircular fiber bundles. Important for us are two other groups of fiber bundles, important for if we would like then to prove the presence of periodontal regeneration. The dentogingival fiber bundles, which you may see here, apically to the cemento-enamel junction, and the dento-periostal fiber bundles, which are not shown in this illustration, but which I will show you here in this histology, this ground section showing the apical end of the enamel, the junctional epithelium in the intimate contact adherent to the enamel, and here the dentogingival fibers which are coming in, and from this side the dento-periostal fibers. The course of these fibers again can be shown even more pronounced with polarized light microscopy. You have here again absolutely the same area, apical end of an animal, and the dentogingival fibers and the dento-periostal fibers. Again, very impressive is to show, to illustrate this area or to evaluate this area with scanning electron microscopes, showing these dense bundles here attached to the cementum surface. Another important tissue in this area is the junctional epithelium. The junctional epithelium, which is shown here and is along this blue line, apical end here at the cemento-enamel junction. This junctional epithelium is composed by 2 or 4 layers of epithelium cells. If we concentrate to the innermost area, to the innermost surface, to the surface of the innermost cell layer, then we will see, if we are lucky, hemidesmosomes, if you are lucky because they are so terribly small, hemidesmosomes, areas rich in adhesive proteins which allow for the attachment, for the adherence of the junctional epithelium to enamel in case of a tooth or to an abutment in case of or to an abutment. If you lose the junctional epithelium, it is pretty easy to gain a new one. A junctional epithelium may form de novo in between 14 to 21 days, and until it is fully matured and attached to the surface. Very important then, the peripheral defense. The peripheral defense, we have 2 barriers, an outer one, a first barrier in the sulcular epithelium. The sulcular epithelium is characterized by a continuous cell shedding, which takes place. You see here these cells which are removed from the epithelium and released in the sulcus, and these cells carry with them a lot of bacteria. So this is the first barrier of the peripheral defense. Then we have a second barrier, a more immunologic barrier by granulocytes which will leave the blood vessels and pass through the junctional epithelium towards the sulcus. When they encounter bacteria, of course, they will remove them by phagocytosis. Here you have the blood vessels, these blue areas, and the widened intercellular spaces of the junctional epithelium where the granulocytes have to squeeze through. And this we can demonstrate at higher magnifications. You have here the connective tissue, granulocytes, which are passing here through the connective tissue towards the junctional epithelium, and then they enter the intercellular spaces here and squeeze between single cells in a direction towards the sulcus. Without this peripheral defense, no tooth would survive. But as it is with defenses, defenses, each defense may become overwhelmed if there are too many attackers. And this is what happened here. Bacteria will destroy the junctional epithelium. The junctional epithelium will then be replaced by a pocket epithelium, meaning that a deep pocket is formed here between the gingiva and the tooth surface. Here you have an animal. These dark areas are accumulations of bacteria, in this case most of them actinomyces. They are surrounded by granulocytes, but they have, against such a large amount of bacteria, no chances, but of course they try to stop them, and we have here the wall of the pocket epithelium. Then it may be that we have subgingival calculus. They look like these little hills here, and by that they work like a foreign body beyond the tissue, and this foreign body will result then in resorption of the alveolar bone crest by osteoclasts, and here you have these nice little fellows, the osteoclasts, which are able to eat away the bone in no time. Then finally we have a more exotic example of supragingival calculus. Here you have the border between an animal and the cementum, supragingival calculus, and a lot of bone destruction which here took place. Now, what are the histologic challenges to prove periodontal repair, regeneration, or regeneration in a correct way? First of all, you need histology of a quality which clearly allows you to distinguish between new attachment up here, where you have new cementum, or probably I should say you that the base of the defect was here. So you have here new cementum and new attachment of collagen fibrils, meaning new attachment. Or you may have here new cementum on the diseased dentin surface, new bone formation, and the presence of newly formed connective tissue, meaning regeneration. Or you may have a long junctional epithelium, meaning a healing by this epithelium. What we definitely need are notches to be sure where we have to measure for the histomotic evaluation, and what we are doing all the time is a micro-CT when we have such specimens to localize these notches and to be sure that we are not doing any mistakes during measuring. In the histology, you have here the upper notch and here the lower notch, and in between here periodontal regeneration. Important is that to be aware that new connective tissue attachment requires the formation of new cementum, as I told you, to the previously diseased root surface. That is what you see here. This is dentin, and this is again a view in polarized light. So you have here dentin, the diseased root surface, which was scaled before, and formation of new cementum, and the deeply buried and anchored Sharpie fibers in this layer. So I think it's pretty difficult to show this in a more beautiful way, how new connective tissue attachment can look like. But in addition, we need another aspect to fulfill, and that is that regeneration requires the correct type of cementum in the area. So as for example, the cellular mixed fiber cementum in the apical region of a tooth and in the furcations, and mixed fiber cementum means that we have extrinsic fibers, the red one here, the Sharpie fibers, and the intrinsic fibers, the blue one here, running parallel to the diseased root surface. Or in the more apical, more coronal region areas, we need another type of cementum, the so-called acellular extrinsic fiber cementum. In the supracrestal region, acellular means we do not have any cementocytes in this cell layer, in this cementum layer. It's a very thin layer, but we have the extrinsic fibers anchored in this region. Then, of course, we have to avoid artifacts. Artifacts, as you see them here, are most often the results if you do histology based on paraffin section, what most of the people are doing. We in our lab, we do another technique, as I will show you. This paraffin technique very often results in a separation, for example, of the long junctional epithelium from the dentin surface, or by a separation between the new cementum layer and the dentin. Of course, this shouldn't be. It's an artifact which definitely must be avoided if we clearly want to demonstrate or to show the proof for periodontal regeneration. What we are doing is that we make so-called ground sections through the fully mineralized specimen, and these ground sections really allow to see the cementum here, the sharpest fibers, and very important, this new cementum layer is attached to the dentin surface. But that is not enough. Of course, we have to show how this area looks like. So if we concentrate to this outlined box in red color, then we may see, if we use again transmission electron microscope, that we have here the matrix of the collagen matrix of dentin, we have the collagen matrix of cementum, and this and both must intermingle in a way that we have that no gap will result between cementum and dentin. That still is not enough. We have to show that it's fully mineralized, that the interface is fully mineralized, and the interface you may see here along this dotted line. So you have here cementum, which is mineralized, and dentin, which is mineralized, and definitely no gap in between. Such sections are quite difficult to do. I mean, it's a real challenge to do sections in a nanometer range for transmission electron microscopy, because there is a real risk that you may damage all your diamond knives you have, and it needs a lot to trick to know to be able to do this attachment. New attachment characterized by tiny fibrils, as you may see here, which are directly attached to new cementum or to old cementum. If you again concentrate to the to the box outlined in red color, then you may see here how these tiny fibrils are attached to the fibers, collagen fibrils of the cementum. Good to see here up there. How these fibrils are formed, it's quite easy. Fibroblasts will cover the cementum surface. These fibroblasts then move away from the surface and secrete at the same time these collagen fibrils. This is a real old image I did about 30 years ago, but I never was able to find a better one in a better quality to show what is going on here. You have a fibroblast up there. You see how the fibroblasts secrete these tiny thin fibrils, and these fibrils span down here to the cementum surface. How the fibroblasts are secreting these fibrils, you may see here in the image to your right. You have the fibroblast with the nucleus, the dark area, and the production here of these collagen fibrils. Then we have to make sure that new cementum is covered, attached either to old cementum or directly to the dentin surface. Both is possible and both works perfectly, as I will show you in the following with the results, the findings following the LANAP treatment of hopeless teeth. A study conducted by Mark Nevins and co-workers, human clinical and histologic evaluation of laser-assisted new attachment procedure published 2012. Mark Nevins showed this, demonstrated the result of this study in Corporate Forum 2011 in Miami. Therefore, in short, material and methods, the study was designed to evaluate the healing response to the LANAP procedure. He had 8 patients, 12 teeth preterminate to be surgically extracted were enrolled and consented to treatment with full mouth LANAP therapy. In the first pass, removal of diseased pocket epithelium was done with the values you see here. Then the teeth were aggressively scaled and root planned with piezo ultrasonic instruments. Then a second pass was performed with 650 pulse duration, and after 9 months of healing, en bloc biopsy extractions were provided and 10 teeth were analyzed histologically. Here you see the results. 5 teeth showed periodontal regeneration, 4 teeth showed healing by a long junctional epithelium, and 1 tooth showed new attachment. The results, in short, the 12 study teeth presented with a mean initial clinical attachment level of 11.2 millimeter, probing depth 10.4 millimeter, and recession of 0.7 millimeter. After 9 months, the sites had a mean clinical attachment level gain of 3.8 millimeter and a pocket probing depth reduction of 5.4 millimeter, and this resulted in a post-operative mean of 7.4 millimeter and probing depth of 5 millimeter and recession of 2.7 millimeter. What I will show you, because that was my job in this study, the histology of 1 tooth showing periodontal regeneration, meaning new cementum, new ligament, new alveolar bone. What we always did before histology was microcomputed tomography to show how this root looks like. Then we were able to remove digitally some of the bone here to see what happens underneath the bone. But of course, that doesn't help us in any way to show or to find proofs for periodontal regeneration. I had the values from Mark Nevins for the distance from the enamel junction down to where the defect was, that 9 millimeter. That means from here, and you see it already on the color. From here up here, we found periodontal regeneration, and up here a sound and healthy junctional epithelium. If we concentrate first to this area outlined here, then we may see new cementum here and new bone over there and new attachment of this chunks of the collagen fibers in the supracrestal region, and the junctional epithelium for in intimate contact to the dentin surface, so the sealing is performed. At higher magnification, it is beautiful. It's very nice to see that we have here the new cementum and the incoming collagen fibers. This is another stain here. Its stain is acid fuchsin, and this stain stains only parts, tissues which are mineralized. So we are using this to show mineralization in this area. And here you have the cementocyte. So it means we have here a cellular cementum. Again, polarized light viewed in polarized light demonstrated the course of these fibrils in an even better way. And if we concentrate to the next box here, periodontal regeneration area, at the higher magnification, we may see here dentin, newly formed cementum, anchored Sharpie's fibers, beautifully anchored here, very deep anchored, then the old cementum layer and the dentin layer. and we can even go higher with magnification and demonstrate that the newly formed cementum layer is here in an intimate contact with the root dentin. If we concentrate to the periodontal ligament per se, here you have the alveolar bone, here you have new cementum, here you have the periodontal ligament, then it's really nice to see that there is an absence of almost any inflammatory reaction in this periodontal ligament. And there is another point. Here you have cementum, here you have new bone, and this new bone definitely is woven bone. And if we concentrate to this woven bone, then we may see that bone formation following 9 months is still going on in this area, and that was really surprising to me. Then, of course, we had to prove that there are no gaps between new cementum, old cementum, and dentin, and that we did here with a technique, again with scanning electron microscope, but with the backscatter technique, showing the mineralization in this area, new cementum, old cementum, dentin, and no gaps between the single layers. Then the healing via a long junctional epithelium, easy to show, to demonstrate in the next image. Here again we have had a defect of 9 mm, and you may see here the long junctional epithelium which proliferated down to this point, so healing by this long junctional epithelium and no regeneration, of course. New attachment, the last thing I will show you, cementum, newly formed cementum or old cementum, and the new attachment we found in one specimen by fibrils here, directly attached to the cementum surface. In the same biopsy, we found in the apical area a notch, the notch here, and again you may see here that the cementum formation is still going on. You have here the cementoblasts beginning initially mineralization in this area. You have the collagen fibers, not very impressive to see in this histology, but again, if we show this in polarized light, then we may see here that everything is ready. The fibers are here, and now the mineralization which will start, and this means then a formation of new cementum in this area. Taken together as a conclusion, the histology of this study provides further evidence that periodontal regeneration or new attachment may take place following treatment via LANAP. Now it's time to say thank you to Millennium for the invitation to be here and to present on this stage. If you need more information, if you want to see more images from our lab, you can go to our website or send me an email if you have questions. Thank you very much for your kind attention.